words, and pleased to be here again. I want to wait for the slide, but I will try to present some data we have from our own registries in Denmark about the new oral anticoagulants, and I have modified the title a little bit. The new oral anticoagulants holding their promise outside clinical trials. What we know is that atrial fibrillation is a very, very common arrhythmia affecting over 30 million people worldwide, and we know that atrial fibrillation increases the risk of stroke by factor 5, and is responsible for approximately 20% of all strokes, ischemic strokes at least, are due to atrial fibrillation. And we know that atrial fibrillation is strokes related to atrial fibrillation are associated with considerable elevated risk of morbidity and mortality. And we all know that oral anticoagulation is recommended to prevent stroke in atrial fibrillation patients, and at least in those with one or more risk factors. And we have for many years used warfarin, which was the only available drug for this indication. But recently, and we have got new drugs available, what we call the new oral anticoagulants, or non-vitamin K oral anticoagulants, what we shorten as NOACs, and they have been considered a good alternative to warfarin. But our knowledge on these drugs is mainly from randomized clinical trials, and those are very selected populations, and patients in these, the population in these trials do not necessarily represent the average population, the population we are seeing in our daily clinical practice. And data on real life data is still very limited on the NOACs in atrial fibrillation. So just to quickly to consider the scope of the problem, and we know that atrial fibrillation is increasing. It increases with increasing age, and we are getting a population that is more age, is elderly. We have a demographic challenge, and when we have the elderly population, we will have more patients with atrial fibrillation, and age is one of the strongest risk factors for stroke in atrial fibrillation patients. And if we consider the management of atrial fibrillation, it has two broad objectives. It has to prevent complications, that includes thromboembolism at least, and particularly ischemic strokes and heart failure, and also relief of symptoms. What I will consider here is that we have this balance between benefit and risks, which we have to consider when we are choosing the most appropriate anticoagulant therapy for our patient, and that's the risk of thromboembolism has to be weighed against the risk of bleeding. And I hope you all are, or assume that you all are aware of this. We use, at least from the European Society of Cardiology, we recommend to use the CHADS-WASH score to stratify patients according to thromboembolic risk. It includes congestive heart failure or left ventricular dysfunction, hypertension, age over 75 years, which gives double points. We have diabetes, stroke or a previous stroke, or transient ischemic attack, for thromboembolism, which also gives 2 points, and then we have vascular disease, age between 65 and 74 years, and female gender as a category. And then if you look at the right table, you can see that not too surprisingly, if you have more risk factors, you have a higher risk of stroke. And we usually consider patients with CHA2DS score of 1 having intermediate risk. We recommend oral anticoagulation in these patients, and for patients with score of 2 or more are considered high-risk patients where we have an absolute indication for oral anticoagulation. And then we have the back side, or the flip side of the coin. We have the bleeding risk, which needs also to be considered. We have, and there we use the Hasbled score. And unfortunately, some of the risk factors for thromboembolism go again in the risk for bleeding. So we have AIDS and previous stroke and bleeding history, patients that are complicated or difficult to control in therapeutic range, and patients who have abnormal liver or kidney function, and patients who are receiving other kinds of drugs, and that's primarily antiplatelet drugs and NSAIDs as an example. And here you can see we use the same classification for the CHATS, previously used CHATS score. I'm not going into details with that. Okay. And we know we have had these. We have at least 3 major trials for the drugs that are currently on the market. We have the REALIZE study, the ROCKET atrial fibrillation study, and the Aristotle study that have proved the benefit of the new oral anticoagulations compared to warfarin. We have lower risk with dabigatran and apixaban at least, and similar risk with rivaroxaban. And then we have recently the ENGAGE study that has with edoxaban that is recently approved in Europe at least. But compared to warfarin in the clinical trials, they reduce the risk about 20% compared to warfarin. But that's in the range of clinical trials, at least in these populations. And similar, if you look at safety, we have the risk of if you look at the first graph here, it's the risk of ischemic stroke, similar risk, but we can see that the NOACs reduce the risk of hemorrhagic stroke considerably, and even though they are rare, it is maybe a devastating complication. We've all probably seen patients with a hemorrhagic stroke that get severely disabled afterwards, and it also can be fatal. And we also see that some of the drugs, at least for apixaban, actually reduce mortality. And then if you look at safety issues, we see that if you look at major bleedings as a safety, we see also that the NOACs, the new oral anticoagulants, have lesser risk, at least combined. It's almost significant for lower risk of bleeding, and we see especially the Aristotle trial. It seems like apixaban has lower risk. So let's see if for real life patients these data translates into the same effects. So what we did is to took all patients with non-valvular atrial fibrillation in Denmark and looked at those who started treatment during the period of 2011 when the NOACs were the first NOAC came into the market in Denmark until 2015. And these patients were naive that they had not at least received any prescription within the first 6 months before. And we looked, in this study, we looked at the safety issues, we looked at compliance, that is the breaking treatment of at least 30 days, and we looked at major bleeding risk. This is just to look at the baseline characteristics of the population. They are older than they are in clinical trials. They are with a mean age of between 70 to 77 years, and they have more risk factors, more comorbidity, higher HAS-split score, and higher CAT-SWAT score. So those are high-risk patients. When we look at compliance, we used apixaban as the reference in this analysis. This is a Cox regression analysis. We can see that for all of the drugs compared to apixaban, at least warfarin has a hazard ratio of 2.17, for dabigatran 1.5, and for rivaroxaban 1.11. So it seems like patients started on apixaban have a better adherence to treatment compared to warfarin and the other NOACs as well. And when we look at another safety issues, we looked at short-term bleeding, that is within the first 90 days from start of treatment, and then long-term bleeding, that is later on. And here we also use apixaban as the reference, and we can see for short-term bleeding, warfarin has a hazard ratio of 1.88, rivaroxaban 2.37, and dabigatran 1.9. And for long-term bleeding, it's not significant longer for dabigatran, but highly significant 1.39 and 1.62 for rivaroxaban and warfarin. So it seems like the research from the clinical trials translates into the same effect with regards to safety for at least apixaban, that it has lower risk of bleeding, serious adverse events. So, yeah. So I'll move quickly forward and look at another study. These are data I have from Dr. Stacks, who will present another data later on. So I'm happy to have the opportunity to present her data. Similar population, non-valvular atrial fibrillation, patients during the same period, similar baseline characteristics, higher risk, more comorbidity, higher bleeding risk compared to the clinical trials, older patients considering the clinical trials at least. And here we have the first, these are cumulative incidence curves of stroke and thromboembolism. And you can see that warfarin or vitamin K antagonist here is the black line, and you can see they almost transpose into each other. So there is it seems not to be any significant difference between the drugs. There are overlapping confidence intervals. And when we look at ischemic stroke alone, that's the ICD-10 code for ischemic stroke, if you're interested in that. And we have completely the same research, no difference between the NOACs and warfarin. So we are not seeing any difference in efficacy between the drugs. Then we also wanted to look at intracranial bleeding. I'll switch slide here. And we all see very similar. We have a very low cumulative incidence of intracranial strokes, which are a rare event. And if you look at in a regression analysis, we see that for we see that the same results. There is no significant difference within stroke and thromboembolism generally compared to vitamin K antagonist of warfarin and for ischemic stroke. And if we look at the intracranial bleeding, we see that dabigatran at least has a much lower risk of intracranial bleeding compared to warfarin. We also saw that in the real-life trial. And we also see that for apixaban, which has a hazard ratio of 0.55 for intracranial bleeding. So at least we are not like having any more protection for ischemic stroke, but we are having less serious bleeding-related strokes for dabigatran and apixaban. So for the efficacy of the drugs, we have that patients initiating dabigatran, apixaban, and apixaban had a very similar risk for stroke and thromboembolism as for warfarin, but we have a lower risk of intracranial bleeding for dabigatran and apixaban compared to warfarin and rivaroxaban. So, thank you very much for your attention.
Thank you very much.